Hello and thank you for joining us on the Pure Pod, a podcast brought to you by Pure Sports Medicine. My name is Tom Ritchie and I'll be your host. Today I am joined by Dr. John Etherington and Claire Small. John is Pure Sports Medicine's Medical Director and Claire is Chief Clinical Officer. How are you both doing today?
Very well, thanks.
Yep. So today we're going to be talking about access to care and the management of long-term health conditions. I'd like to start with looking at those long-term health conditions, in particular, what we can broadly define as chronic or lifestyle diseases. So what are some of the barriers to care that the average patient might come across in managing these conditions, Claire?
I think the biggest barrier is actually access to treatment for those conditions outside a sort of an acute scenario. So we're very good within healthcare at managing something when there's a problem. But what we're not very good at is then looking at how we deal with it in the longer term, how we prevent it getting worse, how we actually try and sort it out with anything other than medication, really. And the NHS just isn't set up for managing those conditions in any other way, generally speaking, other than with medication.
I think there tends to be an underestimate of the effect of these conditions on people, both by the person it's affecting, but also by society and the health service as a whole. So it's very easy to think about treating someone's acute injury or illness, like a heart attack. It's not so easy to think about how you manage their chronic pain or musculoskeletal conditions, or indeed concerns after a heart attack. So we're not good at recognising the importance of that, both to society and to the individual as a whole.
And I think that's, we talk about, we deal predominantly with musculoskeletal conditions. And one of the things we say is that no one's going to die of a musculoskeletal condition, but they often will die of the comorbidities, the other problems that they develop as a result of not being able to exercise and things because they've got arthritis or because they've had a sustained a broken leg that then means that they're not able to function and do the sort of sport and activity they want to do.
Yes, and talking about arthritis, people with rheumatoid arthritis die early, but they die early of cardiovascular disease. So they die of coronary artery disease, and that's probably a function of that sort of chronic inflammatory condition, but it's also a function of inactivity, poor diet, poor general health, and so it's naive to think that if we're going to treat the rheumatoid arthritis, we're not treating the general person as well, because those are the things which are going to make a real difference to both their longevity but also their quality of life.
And if we look at some of the waiting times on long-term health issues in the NHS, I've got some stats here. There are 646,000 people in the UK who are currently not working because of chronic pain related to a musculoskeletal condition. Wait lists for Tier 3 weight management can exceed 20 months. What are some of the risk factors? We've touched on some of them there, but what are some of the risk factors associated when patients can't access treatment for these types of conditions?
Well, some of the risk factors are that they develop other conditions associated with the inactivity, the poor diet, the poor lifestyle, and that because of they're in pain. And then, there's also the idea that if you're not working and you're not doing something that has meaning, that also can have serious effects on your mental health as well. So it becomes a huge vicious cycle, because then you develop other problems which then make it harder to get back to work or harder to do the exercise and change the diet that you need to do in order to get healthy.
Yeah. And I think, again, one of the things which is not thought about greatly in this population is their occupational outcome. So if you're not well, if you're not fit, you're often not working. I noticed that of the people on NHS waiting list at the moment, 56% of them are in working age groups. And if you're not working, then that's not good for you, both in terms of your mental health, your physical health often, and obviously your income. And it's not good for society. And again, as a society, we don't focus on getting people healthy to work. And good work is healthy. It makes you live longer. It makes you feel better, and it's better for society. So I think there's not just a loss of health, there's a loss of well-being as well through these musculoskeletal conditions. And that might be arthritis, but it might be a bad back. If you can't work, you can't work, and your family are put into difficulty, and so are you. So we really, as a society, don't focus enough on getting people back to good occupational outcomes.
I wanted to specifically touch on the current state of the waiting list for rheumatological conditions as well, John. Is that something that you could add some?
Yeah, I see a lot of patients who are waiting to be assessed. I have patients where we have a diagnosis and they're still waiting to be assessed, but it's very variable. I mean, in some areas, it's you can be seen by a rheumatologist within 6 weeks. In others, it seems to be a year, and that variability is even across London, so it's not just sort of national variability. The problem with that is, firstly, there's a delay in diagnosis, and that can have implications. Secondly, people are suffering quite badly, often young people, where there is treatment available if if you can get to it. So that there's a lot of morbidity brought onto the patient because they're not being seen quickly.
Yeah, people say to me, you work in private healthcare, you only see people that can afford to see you. And, I say to them sometimes, actually, we see people who can't afford not to see us, people who need to get back to work.
Yeah.
If you're self-employed and you can't work, then you've not got an income. So, you need to invest in your health by paying to see somebody in order to actually be able to get back to work.
Yeah. And we see, increasing numbers of people who self-pay because they need to do that. It's an investment in their life to keep working, paying the mortgage, looking after their family, and that that unpredictable access to the NHS is a problem.
We've touched on it, but I think it's worth maybe going in a little bit more detail here about just your general well-being and your mental health when you're experiencing these long wait lists, when you're experiencing these long waiting times. Is that something that you see when people come into to Pure, that they're coming and they're presenting with some level of anxiety or even depression because of their lack of access to care?
Yeah, and I think we do see the effects of not having a diagnosis, not knowing what's wrong with them, the levels of anxiety that brings. And I think one of the things that we do when we see patients, the first thing you do is provide them a level of reassurance, that there isn't anything dreadful. There isn't anything that they need to be, unduly concerned about in terms of being able to make a diagnosis. And that's actually the first thing people want to know is what's going on, what's wrong with me. And if you feel that you can't navigate the system effectively, or you're having to wait too long to get that information, it induces a lot of anxiety for people.
Yeah, I mean, I think a large part of the consultations I have with young people with arthritis is about their psychological health and how they address the problems they're facing. I can give them medication, but actually there's a psychological consequence to being diagnosed with a chronic disease, and trying to overcome that and give them back that sort of locus of control back into their lives, so they're controlling their lives again rather than a disease controlling it. So yeah, it's a big psychological impact for patients with these conditions, particularly if they're not being rapidly seen.
I think often too, what people do when they've got, when they're in pain or when they've been given a diagnosis of something like arthritis, is that they stop exercising, they stop being active. And that therefore has a big effect on people's mental health, especially because for a lot of people, nowadays, a lot of people use sport and activity. It's part of their social life as well. There's a lot of information about Gen Z now who, they're not going to the pub, but they're doing things like social sort of running clubs and sporting activities. Now, if you are injured or in pain and you can't participate, it has a massive effect on your social life, which then also impacts your mental health and things as well. And then it becomes an ongoing problem. And that's why, tackling things as early as possible is so key. The evidence is that sort of 5% of people with back pain utilise 95% of the NHS resources because chronic problems actually then becomes something that the system has to deal with and manage. Whereas if we get in early and nip a lot of this sort of stuff in the bud, we can deal with things a lot more effectively. And that's why, in terms of looking at chronic disease and lifestyle diseases, the more we can do to prevent them happening, the more cost effective we are in terms of both the NHS, society, but just for people's own personal spend as well.
Yeah, I see a lot of patients who say I use running or sport or gym as an outlet for their mental health issues. Mm-hmm. You take that away from them, and their mental health control goes out the window. And so, getting people back into physical activity when they're ill is really important, and it's actually a very good treatment for most forms of inflammatory arthritis, and particularly the cases I see a lot of, which is axial spondyloarthropathy, responds incredibly well to the right type of physical activity. Now, often people have been told, don't do any activity, sometimes by doctors, don't do any activity because you'll wear your joints out, which is a nonsense. And actually the physical activity that we can bring to them often helps them considerably and is the sort of first step in their recovery.
And the physical activity, I mean, we always say exercise is the wonder drug, don't we? It's not just things like arthritis or musculoskeletal problems that exercise makes a difference to. The evidence about the benefits of exercise for diabetes, for heart disease, but equally for cancer. The evidence that says people who have cancer should be exercising because it actually helps treat the disease, treats the illness. It reduces the side effects of other treatments like chemotherapy and radiotherapy. It makes those treatments more effective. But yet the general consensus is that when somebody gets a diagnosis like cancer, we stop them exercising. We wrap them in cotton wool and we put them on the sofa and tell them not to do anything. And, obviously when they're having things like chemotherapy or radiotherapy, they can really feel quite unwell. And the last thing that they think or want to do is exercise. And yet if you can get them to do even just a little bit of physical activity, it actually makes them feel better. It reduces the fatigue. It reduces the nausea associated with other treatments and things as well.
Yeah, and for cancer, there's increasing levels of data coming out to show that it improves survival rates, particularly in breast cancer. So, exercise post-treatment for cancer is really important.
And as you say now, because treatment is becoming so effective, more and more people are actually living with cancer.
Yeah.
And again, they need to be, in order to be active participants in society, they need to be fit and healthy. And that's where exercise comes in and making sure that they are fit to work and things as well.
What options outside of the NHS are available for people who want to take more control over their health to kind of, as you said, nip these chronic lifestyle diseases in the bud at the pass before they can take hold or start presenting acute problems? John?
Clearly pure sports medicine delivers that sort of thing. And the key is, from our point of view, is this sort of combination of what we like to think of accurate diagnosis, early treatment, but also trying to get our patients to understand that lifestyle changes will make a difference both in their recurrence rate of injury and illness, but also in terms of managing that injury and illness. And so we're very much wedded to the concept of a multidisciplinary team and bringing all elements of that treatment together under one roof. I think it helps the patient. I think it helps them to understand, again, that they are in control of this condition. We can't deliver everything. We can give them advice, sometimes medication, but and we can give them physiotherapy. But fundamentally, it's about lifestyle modification. It's about exercise. It's about diet. It's about not smoking. It's all the good things we know we should do, but it's supporting those people in taking up those good things.
Yeah, I mean, we've got a team of exercise professionals who are specifically trained to help people, support people who have those long-term health conditions, cancer, cardiac conditions, metabolic disease, diabetes, osteoporosis, all the things that actually do have a real effect on people's longevity. And if you're given a diagnosis of, a cancer diagnosis or a cardiac, that you've got a cardiac condition, you don't just want to go and see anybody, because you've got, you want to see someone who's not going to hurt you and damage you. And so you want to see someone who's got expertise in that area. And the other great thing, obviously, is that we're very lucky that those exercise professionals are then supported by a team of consultants who, obviously are medically trained, and so that there is support there if there are concerns about, unusual side effects and things as well. But there's very few people who, with a long-term health condition who shouldn't be undertaking some form of exercise. The biggest thing, for a lot of people is knowing where to go, is knowing who to see and finding the right people. And again, that's where, especially because the NHS is set up as something that will treat people from cradle to grave, often there isn't a lot of information out there about alternatives. And, choice, I'm a big believer that people should choose how they want to look after themselves. And some people choose that they, will go on an NHS waiting list. Some people, that is their only option. And it's really important that we make sure that they have access to, high quality evidence-informed healthcare. But there are people out there who, would choose to spend their own disposable income on seeing a healthcare professional to help them. And it's really important that those people know what the options are and what's open to them.
Yeah, I think the advantage we have is that we have a group of professionals trained in different areas who can support each other. So if an exercise physiologist is taking someone through an exercise program, has a medical query, they can literally tap on the door and ask me about it. And likewise, I can ask a physio about the best approach to a physical rehabilitation problem or manual therapy or whatever. And I think that really supports the patient, makes them confident knowing that they're in this wrapper of people that know what they're talking about and actually care about their outcomes. And those outcomes are physical and psychological outcomes which that patient has chosen themselves. They're focusing on themselves, not imposed on them by us or others.
I wanted to pick up on something that you said, Claire, which is that, obviously people think that the NHS is set up to treat them from cradle to grave, as you put it, but people might not know that they have the option to self-refer on these things. Is that something that you found, that people who eventually make their way to you, but they didn't realise that they could have come much earlier?
Yes, I think that, and that's the understanding of how the private healthcare system works is really something that people don't know a lot about. It's not talked about. I think because we talk so much about the NHS, and often people don't realise that they can self-refer, that they can self-fund. They don't have to have insurance in order to see someone privately. That they, they're also often sometimes surprised at the cost of things, that they actually think things are going to be a lot more expensive than they are. For example, getting an MRI scan or some blood work. There's a lot more of those things available now privately. So the cost of a lot of that has come down considerably. And, a lot of people are happy to pay because they want, as we've talked about, they want the reassurance, they want the diagnosis, and they value their health. And and they also say that ultimately everyone values their health, becomes the most important thing to them as we get older, and we start to realise that we're not invincible, and that's when we do start to think actually we are happy to pay more for looking after ourselves. Though again, there is evidence that the younger generation are actually seeking out private healthcare services and are willing to do that because for them, their health and well-being, physical and mental, is such an important thing. It's something that they value.
Yeah, I was a bit disturbed when we're talking about the elderly when Claire looked at me. But I can take her point. I think that's right. I mean, it's interesting concept, and we discuss this a lot, that most people are prepared to pay quite a lot of money to get their car fixed, but are not prepared to think about that from their own personal health point of view. And I think that's in the UK, it's culturally because we believe that the NHS will look after us from cradle to grave. And the NHS is absolutely brilliant at some things, world class, and it does things that we can't possibly do. But at other things, it's not so good. That's just the reality of life. And if you're suffering from chronic injury or illness, particularly musculoskeletal, you're not going to be the NHS priority. That is the honest point. And that's where I think people are increasingly either self-paying or using their private medical insurance.
And there's also a case maybe that some people might think that if they go private once, that means that they then can't be referred back into the NHS. And there's all these things. There are moments where people can kind of, like you said, for a musculoskeletal condition or maybe other forms of chronic pain, where they can just make that decision, and that doesn't mean that they then can't go back to their GP for another reason.
No, I think GPs are obviously want to do the best for their patients, and if that patient has access to private healthcare, the vast majority of GPs will help them access that healthcare. I think that this sort of feeling that once you're in the private sector you can't go into the NHS is false. I see a lot of patients where my primary aim is to make a diagnosis, initiate treatment, but when they're in rheumatological conditions, when they may need fairly expensive medication, they'll often have to go back to the NHS in order to access that, and that's perfectly accessible, and in many ways that saved the NHS a huge amount in terms of resources in diagnosing and investigating, initial management, all that sort of thing. So I think it's a win-win for both services, really, and certainly means that patients can get seen quicker and have a more definitive approach early on.
I think where the NHS staff get frustrated, and especially for GPs, is if there's a lack of communication. So, one of the things that we really pride ourselves on is our communication, our correspondence to other professionals, so back to the GP with an explanation of what's going on, what we've done, what we've said to the patient, so that there isn't mixed messages. They are getting that sort of consistent message, and we're also explaining what we've done, whether we've done any investigations, what treatment we've done, and also then what we're asking them to how we're asking them to support their patients.
And I think, again, maybe this is something we've touched on throughout the conversation, but I think it's worth asking the question more explicitly is, what are the benefits of empowering patients to take a more active role in their health? Does that actually lead to more positive outcomes for them, John?
Yeah, absolutely. And I think the biggest part of my job, and I'm sure everybody else at Pure, is to do that, is to say, well, this is the condition, but this is how we can help you control it. But fundamentally, you're controlling this by either taking regular medication or managing your health and well-being, or taking regular exercise. But giving that control back to the patient is an absolutely critical part of what we have to do. If I see a 25-year-old person with a newly diagnosed form of chronic arthritis, I'm not going to see them for the rest of their lives. I can't follow them up forever. They are going to be managing this and looking after themselves. Therefore, you have to take them from a position where they feel passively done badly to controlling that condition themselves and empowering them to really get better and stop them getting worse. And that has to be the patient's responsibility. I can't do it forever.
Well, when we built the first Pure clinic, so the first one we really built was our clinic in Bank, Threadneedle Street, we made a really deliberate decision to have glass walls so that patients sitting in the waiting room could see the gym and could see the physical activity and exercise that was taking place in there, because we wanted to ensure that everybody realised that a key part of pretty much every aspect, every condition we saw was exercise, and that's what gets people better. And so that people coming into our clinics know right from the word go that this isn't a passive approach to healthcare, because the evidence says exercise is what gets people better. And that might be very specific exercise for a tendon problem or an ACL injury, a ligament injury to the knee, which is really common, or it might be cardiovascular exercise for for their heart and things. And again, the evidence that our VO2 max, our level of our fitness is a really accurate diagnosis, indicator of our well-being and our longevity. It's not just about our heart health; it's about things overall. But the other thing that's really important is, which we know there's increasing evidence around, is the importance of muscle mass and not losing muscle. So strength training and those things, both the sort of fitness side of things and the strength side of things, are absolutely essential for us to live a long but also healthy life. The evidence is that we're living longer, but we're living longer in ill health. So, and actually that's not what people want. They don't want to live longer, but actually have, the last few years of their life being really poor quality, whether that's sort of a physical, illness or things like dementia, Alzheimer's, etc. They want to live well. And again, the evidence that for things like Alzheimer's and dementia is that physical exercise is actually something that prevents those things deteriorating and getting worse as well.
Yeah, I think actually this has reminded me of something that's happened to me over the last year. So I play rugby, and last September I was presenting with quite a lot of knee pain. I went to see my GP, and they basically told me, stop playing rugby for at least the next couple of months, but I'll refer you to the physio. And I said that to the physio, and the physio basically said, do these exercises, we'll get the strength back up in the muscles around the knee, and we can get you back on the pitch really quickly. Now, that's probably the caution of the GP, just to make sure that the situation doesn't get worse, versus a physio whose goal generally is to make sure that you can do the things that you want to do. And that's empowering to me, right? Because it means that I then have to go away and do those exercises to achieve the goal that I want to achieve. And sometimes when you access the avenues of care that you typically might be used to, which in this country would be going to your GP, going through the NHS, that might not happen. So I definitely agree with the point that empowering people to take control over those situations really helped me, definitely helped me.
And the difficulty for GPs is, sometimes they say sort of 30% of what a GP sees is a musculoskeletal conditions in the clinic. But they've got, sometimes 8-10 minutes to actually try and that's really not enough time to make an accurate diagnosis. It's definitely not enough time to then prescribe an effective sort of treatment program and things for people. And again, in terms of not wanting to make anything worse, if you haven't actually made a diagnosis, then often the tendency for any healthcare professional would be to say, stop what you're doing until we know what we're dealing with.
Do no harm, right? So, yeah. So, Claire, you mentioned retaining muscle mass as being a very important indicator of long-term health. What are some of those other indicators, and how can they help in the prevention of lifestyle diseases?
So we know that muscle mass is really important because muscles have a phenomenal impact on the way that our body functions. So they have an impact on the way that our body uses sugar. They also release all sorts of chemicals. So they release chemicals called natural killer cells and tumor necrosing factor, which actually then deal with inflammation and things like cancer. So strength is really key. In terms of prevention, we've talked also about the idea of fitness, so the level of your cardiovascular fitness, and one of the best indicators of that is a VO2 max test, where you look at how effectively your system is using oxygen and things. But there are a lot of people who aren't necessarily up to doing that sort of test. I mean, there are a lot of other tests that we can use, walking tests and bike tests and things, which look at people's people's fitness and things as well. But we also need to look at things like, what their diet is like as well. And again, we're really lucky that we've got a great group of dietitians and nutritionists who can really personalise that for people. The thing with diet and is that everyone thinks that they can read it in a book or in a magazine and things. And I sort of say to patients, look, we all know that an apple's better for us than a Mars bar. It's sometimes it's not about the information. It is actually also then about how we personalise that to make it work for our lifestyle as well. And again, we know that that's because what we eat, it's not just about calories as well, which is what the old thinking process was. It is about, what we're putting into our body to allow it to act, in an optimal way. And some of the ways that you would actually measure that is by, is with some of the blood work that the doctors would look at and things as well. So
yeah, I always eat an apple after a Mars bar,
Yeah.
just to have a balanced diet. I think, all those I absolutely agree with. I think the other thing, particularly in some of my rheumatological patients, is flexibility as well. And a lot of people don't focus on that. So things like yoga can be really helpful, particularly with some of the more severe joint pains I get.
There was something that you mentioned there, Claire, which I guess is what we could broadly refer to as like the action-intention gap, right? That people know this information, they know how they should be eating, but they don't necessarily action it in their day-to-day lives. And that's something that a health professional can really help with as well, right?
Yeah, because again, it's about understanding that individual and then personalising it. But it's the same with exercise. Again, people say to me, "What's the best form of exercise to do?" And I say the one that you will do.
Yeah.
And again, there's lots of sort of like, oh, is yoga better for you, or should everyone do Pilates and reformer Pilates, or should we be doing spin sessions on the bike, or should we be out jogging, or is jogging bad for us? Is it going to make your knees worse? Now, there's absolutely no evidence. In fact, there is evidence to counter it that says that running gives you arthritis. In fact, again, we know that that's not the case. So, exercise and physical activity is prevents those sorts of problems. But again, it's about understanding the individual and helping them, empowering them to make the changes that they need to. And again, that's one of the difficulties for people within the NHS is that the healthcare professionals simply do not have the time to spend with individuals to really understand, those things in many cases.
Yeah, I absolutely agree with that. I think the key is getting people to do something. And I think there's been too much focus on how many minutes or how many steps or whatever. The Moving Medicine initiative through the Faculty of Sport and Exercise Medicine is really important in this, because what it says is it doesn't matter what you do as long as you move. And if you're moving a bit more tomorrow than you did today, that's even better. But that movement might be dancing, it might be gardening, it might be walking, it might be walking up the escalator instead of standing there. It might be playing a sport. Whatever you like to do it, but get moving. And somebody once said to me, the hardest thing about training is putting your training shoes on, because once you do that, once you start, most people enjoy it. And if you are particularly, fascinated by badminton, do that. It doesn't really matter. Yeah, if you're doing very, very highly intense exercise for very many years, maybe there's a consequence on your joints. But actually, for most recreational athletes, it's absolutely the best thing you can do.
And the variety, isn't it? I mean, that's one of the other key things. As John says, you need to be flexible, you need to be strong, you need to have good heart health. So often variability is the key. I mean, it's one of the challenges for elite athletes who are doing the same thing all the time, using the same muscle groups, is maintain that they don't develop overuse injuries, and that they try and keep, they do other things to keep that balance. And again, when I talk to patients and I sort of say, well, we see the elite tennis players and we see them on the court. What we don't see is what they're doing off the court to keep themselves, injury free, and all of the sort of the gym work they do, the soft tissue work that they have to maintain their flexibility, the stretching and things. And then, obviously looking at all of the sort of gym work for strength, for agility, and then also the things that they're looking at in terms of their diet. So it's not just about going out and playing loads and loads of tennis. In order to keep them injury free, they need to do a load of other things as well.
Yeah. And final question for today. So thank you for your time. I think we've spoken about it, but again, I think it's worth asking the question explicitly: is how does the personalization of care delivered by an MDT deliver better outcomes for patients?
Well, most studies show it does, and most studies can't tell you why it does or what bit of it does. And in fact, I've just been reviewing this for trauma rehabilitation. There's a big debate about, well, what component part makes a real difference, and you can't find out. And the reason you can't find out is because it's like a cake. What's the best bit of the cake? What's the important bit of the cake? Well, I can tell you what the important bit of the cake is if you leave it out. If you leave the eggs out, it doesn't taste of anything. But likewise, in the MDT, you've got to have every component part, and you've got to have that component part talking to each other and talking to the patient and working with the patient to find out what they want to do, and then working together to get there. And most data in most areas of rehabilitation, be it musculoskeletal or cancer or whatever, showed that you need a team to do it better. But it's a little bit magical what it actually does. But what I think it makes a difference for me is I know what everybody else in the team's thinking, because we're talking about the patient all the time.
I can't believe John's used a baking analogy.
Yeah.
Looking forward to the
Well, I'm looking forward to the
chocolate
cake.
Yeah, exactly. That's right.
Claire
Yeah.
bakes. Hint, hint.
I'm looking forward to the chocolate cake arriving at the next senior management meeting.
Okay.
Yeah.
I bring fruit, of course.
I think one of the things John just talked about there is the communication. And again, I think that's what is one of the big key things is, again, consistent messages for the patient, consistent reinforcement, which encourages them that they are doing the right thing. If you're getting mixed messages from people, so you're being told one thing by your physio, something else by your personal trainer, and something else by your GP, you're probably likely to do none of it because you're not sure who, whereas if you're getting a consistent message from everybody about you need to be exercising and you need to be doing this type of exercise, and, no, you don't need to worry about that niggle when you're doing the exercise. That's nothing to be concerned about. Then that motivates you to keep going. And, that's I think one of the biggest things is that everybody's looking at the patient and putting the patient at the centre of their care. And again, that's one of the things that we're really fortunate because we all work in the same, building as well, so we can pop in and talk to each other about patients, to check in and things. And the other thing there is that we're all then learning from each other as well. So we're upskilling on a daily basis with little bits of knowledge about how others approach the management of certain conditions and things. And I always say when I'm recruiting staff that's where we do a lot of continuing professional development. We invest in it quite heavily for staff. We provide them funding to do MS masters programs and other courses. But the vast majority of the learning takes place in the staff room when people are having a cup of coffee together and chatting about a patient they've just seen, or someone that they're referring to them, or talking about a patient that they've seen that day. That's where the learning happens, and it's what I call sticky learning because it's situational based as opposed to something theoretical within a lecture theatre.
Yeah, everybody's chatting over a slice of John's cake.
Exactly.
Yeah. I wouldn't recommend it, and that really is probably a negative longevity factor. I think actually the thing is that I've learned a lot from working with physios and strength and conditioning coaches, osteopaths and occupational therapists, social workers, just through that process. And how I practice as a doctor has been informed by all those people I've worked with. and I would be much worse as a doctor if I hadn't done that, but it'd be much less fun as well. It's really interesting. It really inspires you to hear about other approaches, and it makes you a different clinician, and that's why I do it.
Yeah, I mean, I couldn't imagine working any other way now. I would feel like I had lost a lot of the support network around me, and I would feel less capable of managing patients effectively if I didn't have the MDT to work with. And as John says, what I've learnt from working alongside, our doctors, but also the strength and conditioning team, the soft tissue therapists, the dietitians and things, one of the things that we try and really focus on is getting people to play to their strengths. Like, we know that our physios can do some of the strength conditioning work. They can do some of the soft tissue. The question is, are they really best placed to do it? And the answer is no, because we've got others who are experts in that area. And it is about everybody being an expert in that area. It's not about a hierarchy of, passing, things down to, from the doctors down to the physios, down to the strength conditioners. That's not how we work. It's everybody's an expert, and it's who's best placed to take on what aspect of the management of a patient's care.
Claire, John, thanks so much for your time today. Really enjoyed the conversation.
Thank you.
Thank you.